Welcome, everybody, and thank you for joining us tonight for our TIF Talk Tuesday. As you will see, we've got a lot of guests, special guests, joining us today. We're very excited to have Dr. Peter Janu. He's been here before, so you may recognize him. Thank you, Dr. Janu, for being here with us this evening.
Thank you. Really appreciate it.
Thank you. And in addition to that, we've got 3 of his patients. We have got Ryan. Ryan, thank you for being here. We also have Mike. Thank you for being here as well. And lastly, we have Eden. Thank you, Eden, for being here and joining us this evening. So just to start off, I do want to remind everyone this is a live event. So at any time, if you have any questions, please feel free to type them in the comment section and we will do our best to answer all of your questions tonight. And before we start, I do want to give a little, Dr. Peter Janu is a surgeon at Fox Valley Surgical Associates in Appleton, Wisconsin. Dr. Janu has a special interest in heartburn and reflux diseases, as well as minimally invasive laparoscopic techniques, endoscopic surgery, robotic surgery, nutritional support, and hernia surgery. He developed and directed the region's first Reflux Center of Excellence. Dr. Janu has received national recognition of procedures for the treatment of heartburn and reflux and has been teaching and proctoring other physicians both nationally and internationally. So again, Dr. Janu, thank you for joining us and for being here with us tonight.
Thank you so much. Happy to be here.
Yes. So as I mentioned, we've got 3 of Dr. Janu's patients here, and hopefully we will be able to hear all of their stories. We've got some unique stories here and some post-op. Some of them have different dates of when they had their procedure. So hopefully this will help all of you that are watching. Hopefully you can ask as many questions as you'd like, and we'll try to get some questions answered. So, but before we start, Dr. Janu, maybe you can kind of first explain what is GERD, the actual disease state, and what potentially could patients be feeling if they were suffering from.
It's a great question. GERD stands for gastroesophageal reflux disease, and so we say GERD because it's really hard to say that over and over again, but ultimately it means that the content of your stomach is going the wrong direction. And if it is bothersome enough that it starts compromising people's quality of life, for a variety of different reasons, people seek out to do something about it. And what we found over time is that one of the main culprits in the disease state is that the valve at the end of the esophagus where it connects to the stomach typically wears out or goes bad in some way, shape, or form, which then doesn't seal properly, and the contents of the stomach can go the wrong direction. And the symptoms that people experience typically can be heartburn, it can be reflux, it can be feelings of regurgitation. But sometimes people don't necessarily get those typical symptoms. They can either have things like coughing or clearing of their throat, hoarseness, feeling like there's something caught or stuck in their throat, difficulty swallowing. There's all sorts of different manifestations that can occur because it's such a spectrum of disease.
Right. Thank you for that. Thank you for that. And maybe we can talk to some of the patients, kind of what kind of feeling symptoms were you feeling? So Ryan, tell us a little bit about you first. And you are probably the longest out in your TIF procedure. So what kind of symptoms were you feeling, and how long were you suffering?
Sure. I started having major problems with GERD, I'd say back in high school.
Okay.
I was in various athletics and activities, and the GERD was constantly a problem with any type of activities. Sleeping, it just kept expanding from there. So had problems sleeping, kept changing my diet. I wasn't getting any relief there. Went to multiple physicians to try to treat it. Basically, where we ended up was just taking a daily cocktail of pretty much every antacid that you could think of. So I did that for a while. We did explore surgical options, but I mean, this was back in the early 90s. So surgical options back then were incredibly invasive. and I was not interested in going down that path as a younger person then. So it just over the decades, just self-medicated a bit with it, taken a variety of proton pump inhibitors, H2 blockers, over-the-counter antacids, just whatever was available. And one day at work, a woman was she was drinking a smoothie, and some of that I wouldn't associate with drinking a smoothie, and so I was giving her a hard time about it, and she told me that she just had this procedure done from Dr. Janu to help her relieve her reflux. And so we talked about it a little bit, and about an hour later I made an appointment at Dr. Janu's clinic to figure out what it was all about. And that was 8 years ago now. I went through the procedure. It was a success. I know at that point, I had multiple ulcers going on top of the reflux, and just timing was perfect. I just had all sorts of issues going on, and happy to say it's been great. I still do take medications for it, but I take a lot less, and I don't have any. I mean, I forget about it. It's not something I think about very often.
Yeah. Okay.
Which as I was thinking about doing this presentation, I was like, or speaking, my initial thought was like, yeah, it's okay. And then I had to think back. I'm like, no, it wasn't okay. It was a big deal. It was pretty huge.
Yeah.
So just that I think that everything's fine really is a big testimony that how far I came on it.
That's fantastic. Well, thank you for sharing that. And it's good to hear, even 8 years out after having the TIF, like you said, it's not top of mind anymore, right? Then for years it was always, and maybe you could tell me, would you always have to think about what you ate, or if you did activities, was it always top of mind for you? Is that what was really getting to the point where you needed to make a decision?
Well, I had made a decision, I guess, not to do something because I didn't know that there was really anything aware. I'd gone through, I can't even tell you, I mean, every single dietary change you can imagine, a lot of lifestyle changes. And to be honest, it wasn't really a difference. I mean,
okay.
and I got in a routine where I'm like, well, I might as well just, kind of do what I want, and it's still going to be just as bad anyway. So the priority just became make sure I don't leave the house without a couple Pepsids and a couple Rolaids in my pocket.
Yeah. Wow. Crazy. And it's not like that now anymore, right? Or
no, I can't even remember the last time I've taken a Rolaids. I mean, I still take a PPI, but it's a much lower dose.
okay.
And because I was on high dose before, and that was always giving me bloated feeling. I always felt bloated and just was not great. But now I'm on a much lower dose, and with that, I never have a problem. If I skip a day or I miss a day or I don't have it or a couple days, it's never an issue. Once in a while I'll go off it completely.
Okay.
And then after like a week or so, I'll notice. It's not debilitating, but I'll notice, and so I'll just go back on it.
Fantastic. Well, thank you. Yeah, no, that's great. Mike, what about you? Tell us a little bit more about your story. I understand that you are about 6 months out since your TIF procedure. Is that correct?
Correct. Most of my life I've had issues in terms of an upset stomach with gas and a little bit of reflux. And then about 8 years ago, it got much worse. And I went and I saw a doctor, a local doctor, and I went to several seminars to investigate on possible procedures that were available to take care of this problem. It was discovered early on, about 7 or 8 years ago, that I was starting to develop Barrett's esophagus, which was wearing away of the lower part of the esophagus, which can be life-threatening if you let it go long enough. So I eventually started on the PPIs, and one of my goals was to get off of the PPI. And with the research that I have done, I've realized that it's not something that perhaps you want to be on a whole lifetime, at least a heavy dose of it. And as time progressed, I got to the point where the acid reflux got so bad that I would say the 2 to 3 years prior to my surgery, I was sleeping 75% of the time in a recliner. I was unable to sleep in a horizontal position, even with the head of the bed elevated, without having a lot of discomfort, particularly about 2, 3, 4 o'clock in the morning. And that's when I reevaluated where I was, and I said, sooner or later, I have to have something done. And also my eating and drinking was the triggers that were causing the acid reflux were increasing. You know, I had them all pinpointed, but they seemed to be getting more and more and more. And toward the tail end of it, I started losing weight simply because I was unable to eat the foods that I wanted to eat and eat the amounts that I wanted to eat. And so I actually interviewed Dr. Janu. He probably doesn't realize this. I went to his office over at the other hospital, and I interviewed him about 4 or 5 years ago, just after reading about his expertise in the area. And I figured I'm going to just continue to wait and see if this thing is perfected. And I read more and more about him and the fact that he is supposed to be the guru in that area. And I was very pleased when he came over to the local clinic here, and I finally made a decision that it was time to pull the trigger and to do what we did.
That's fantastic. Well, thank you for sharing that. Dr. Janu, did you know you were being interviewed at the time?
But what's interesting about this is that, like we mentioned earlier, that it is quite the spectrum of disease, and everybody's trajectory for where they get to a point where they feel like their quality of life is being compromised is just different for different people. And we'll always say, you know, how much does it really bug you? Because ultimately it's not like your appendix is about to burst, and if you don't do anything today, you get sicker. And so everybody kind of makes that determination on their own, but invariably they will all get to a point where they say, I think I would like to find something better. And in as much as there's a variety of different options that people can pursue, one of the benefits of this procedure invariably is that it has one of the lowest side effect profiles for the treatment, for following the surgery, for the treatment of reflux. And when people are trying to decide what is going to be the best fit for what they're trying to accomplish, if you have some concerns about some of the potential side effects or consequences of some of the alternative options, then this falls into a category that really fits for a lot of people.
Yeah, that's a very good point. And Eden, tell us a little bit about your story and when you started kind of has it been your whole life that you've been suffering with GERD, or tell us a little bit more about that and when you decided to have the procedure, because I understand you're probably the most, you're still in the diet phase of your TIF procedure. So talk to us about when you kind of made that decision, and also your story about suffering from GERD.
Yeah, so my senior year, so I was a senior last year in high school, and I started, I would say during COVID, like January, I started getting like really bad acid reflux, and but not too bad, that I could still make it through every day. I obviously like didn't really realize it until I would say about like Thanksgiving. It got really bad, and like I couldn't really go to work or sleep really. So I think that's probably when it mostly started, was last year, and then got really bad during Thanksgiving. So obviously I told my parents, and then they started taking me to different testing and gone through a lot of testing until I came to Dr. Janu. So yeah, so then I did a lot of testing, and then I went to Dr. Janu, and then I think, and then I had my surgery obviously 4 weeks ago.
Yeah.
So yeah, but yeah.
So what, when you say it was really bad, what were the worst kind of symptoms? You weren't able to eat or sleep, or what were the things that you were kind of suffering from, if you will? Was it like the typical heartburn feeling? Or was it just when you ate certain foods?
It had like heartburn and like just acid reflux on my heart, like my chest just felt like so tight that I couldn't breathe.
Yeah.
And also I lost a lot of weight. I probably lost about 30 pounds in the beginning of all of it, so it was a lot. And I'm a very tiny kind of person, so it's not good to lose a lot of weight. So that was one of the main things to start looking into what was wrong. So
Yeah, wonderful. Now, Dr. Janu, can you talk? I mean, you mentioned it a little bit about, and I think, everyone talked about making lifestyle changes or whatnot, and then some alternative options. And as you had mentioned, every patient's different. From the time when they realize I can't live with this anymore, I need to make a change, to what is the right procedure for me. Talk to us a little bit about what are the different treatment options available today. I mean, obviously, like Ryan had mentioned, he had been on PPIs. He's still taking a little bit of PPIs as well. From medical to surgical options, what are the options?
So, I guess conceptually, this is a problem with the content of the stomach going the wrong direction. And so if people are suffering from what they describe as GERD because they eat an entire pizza before they go to sleep at night, that doesn't mean that you should have surgery. That means that you shouldn't eat an entire pizza before you go to sleep. So we certainly start with lifestyle and diet changes and whatnot, where you're trying to avoid some of the trigger foods and you try to have smaller portions, because ultimately the less that is in your stomach, the less that can go the opposite direction. When people take the medications, sometimes it's a misnomer because people feel like that's a treatment for GERD, when in actuality, it's really just changing the composition of what's in your stomach. The content can still go the wrong direction if that mechanical aspect of the barrier is disrupted. But by changing that composition, if it does go the wrong direction, it might not burn and sting as much, or you might not notice it as well. And so a lot of times people will notice over time is that you'll have medications that can help, but maybe not take the symptoms away completely. And that's when it ends up being more of a content than a composition issue. And what we'll find is that people will try to jump from medication to medication, and whether it's Pepcid or an H2 blocker or a PPI, or taking 2 PPIs, or a combination of this, that, and the other thing. Those are all just basically different formulations to change the composition of the stomach, but it's not really addressing that barrier function to prevent things from going the wrong way. When people finally get to a point where we can kind of document that they have significant reflux and it's becoming this lifestyle limiting factor, then we can consider doing surgeries. And historically, people could have a traditional fundoplication, which means that you're taking part of the stomach and wrapping it around the end of the esophagus to create this higher pressure zone, much like putting a blood pressure cuff on your arm. And it's excellent at controlling reflux, but it does have the potential side effects of having trouble swallowing through it. Sometimes people get bloating issues. Sometimes people get some achiness because of the stitches that are used to it if they get pulled on. And it makes it a little bit harder to vent your stomach and allow the gas to expel. So it does have some potential side effects and consequences from it. Sometimes people can have a partial wrap to try to offset those, but at the same time, it still involves changing the shape of the stomach, and it's a little bit more involved from a surgical standpoint. Some people feel that when the valve has gone bad and it's not working well, we can replace it with a new valve, which is using a magnetic sphincter augmentation device that helps provide a new barrier. What this does is it basically is trying to reestablish the angles and the proper anatomy. And so it's probably the most anatomically correct way of reestablishing that barrier. And by going partially around it, we usually go around maybe 300 degrees around. So it still allows for a little give or flex. So for patients who, let's say, have some issues with swallowing, or perhaps their esophagus isn't squeezing as well as it once did when they were 21, this really doesn't have that much of a negative impact on that compared to some of the alternative procedures. And that's where it falls into that category of having one of the lowest side effect profiles from an option standpoint.
Perfect. Thank you. And, you know, I think one of the big questions to all of you as patients is, you know, what type of research did you guys do before determining, you know, the TIF is the right procedure for me? And maybe you didn't, or you just got information from Dr. Janu in his office regarding the different options. But I'm interested to hear kind of, when you were looking at the different options that are available to you, what made you choose the TIF procedure, if you will? Ryan, I'll let you go first.
I had a referral from a successful case, so that helped. I did some internet research on it, and then just relied on Dr. Janu's expertise. So.
Fantastic. Yeah. How about you, Mike?
You know, I went to the seminars, as I indicated before.
Yeah.
Talked to Dr. Janu and his predecessor, where he currently works with Dr. Doppler, before Dr. Janu went there, and a lot of reading on the internet, and I guess that was it.
Yeah. Okay. And how about you, Eden?
Just information from Janu, and also I have a friend's mom that works in the surgery area, so she referred me to him too.
Okay, wonderful. Thank you. Thank you. We have a couple of questions that have come through, Dr. Janu. Most of them are for you, but let's go through some of them here. And I'm getting a common question that's coming through in regards to the longevity, if you will, of the TIF procedure. How long does it last? So maybe you can talk a little bit about that.
Sure, that's okay. Ultimately, the longevity, efficacy, and durability of this procedure, because it is a suture-based type of repair, is a little bit based on how well people heal and how well their scar tissue holds over time, coupled with the fact that going forward, I always tell people there has to be kind of an adjustment of the lifestyle that offsets what potentially got you there in the first place. And so for patients that had been used to filling up their stomach or eating really fast, rather than eating 2 or 3 big meals during the course of the day, the mantra that we give people going forward is that you have to take small bites, chew your food well, eat slowly, and never eat too much at any given time. And the patients that kind of carry that forward are the patients that I rarely see back. Ryan, for a period of time, we hadn't seen him back until we started seeing each other at the soccer games for our youngest boys. And so that's when I would usually see people, not in the office because they were doing well, but out and about in the community. In general, if you look at the statistics between traditional fundoplication, the results are such that at, let's say, 5 years, 75 to 80% of the time, people are satisfied with how well it's controlling their reflux symptoms. What we find with the TIF procedure is that it's the same. It's about 75 to 80% of the time, people are satisfied with how it's controlling the reflux symptoms. And so it is a little bit of a combination of not only fixing the mechanical barrier of it, but also adjusting the lifestyle to accommodate that going forward.
Yeah, perfect. Thank you. And one big topic that always comes up is the hiatal hernia. I haven't asked the three of you whether or not you had a combined procedure or not, but can you talk a little bit about the hiatal hernia and how that, if you combine that with the TIF procedure, how that correlates and what that can do, and what's the, what's the, how does it, what's the word I'm trying to say, affect each other, and why is it important not fixed, if you will?
Do you want me to answer that question?
Yeah, first, yeah,
okay.
yeah.
Okay, so
sorry.
The term is thrown around quite a bit, and sometimes that's a poorly understood aspect of this, because The passageway in the muscles of your diaphragm, which is your breathing muscle, is called the diaphragmatic hiatus. It's Latin for hole in the diaphragm, so it sounds a little bit more impressive than it actually is, but that's where the term hiatal hernia comes from. And it basically means that that passageway or that opening is a little bit wider than what it's supposed to be. And in general, the barrier that prevents things from going the wrong direction is about 50% the angles and the flap valve at the end of the esophagus as it connects into the stomach. And then 50% of it is actually the muscles of the diaphragm pinching in and kind of sealing the esophagus to prevent things from going the wrong direction. And what people find is that many times both of those components have failed. The best way that I've been able to describe it to patients is similar to brakes in your car, in the sense that there's pads and rotors. There are two aspects of the same thing that are called brakes, but it's basically two components working together to achieve that stopping force. And the same is true of the hiatus and the valve. And so what a combination procedure with this involves is not only fixing the muscles of the diaphragm and making that more snug so that that passageway is actually contributing to the barrier function, and then reconstructing the valve in this more anatomical way so that it has that barrier function, but it's not reconstructing it in such a way that you're changing the shape of the stomach or adding some type of implant. It's just done in a more natural way.
Yeah, perfect. Thank you. Now, Ryan, did you have hiatal hernia repair as well as the TIF procedure, or just the TIF?
I believe I had both.
Okay.
Didn't I, Dr. Danny? Yeah.
You did, yeah.
How about you, Mike?
Yes, I had both.
Okay. And then Eden?
Yes, I had both.
Oh, you both? Okay. You both? Okay. Okay. Fantastic. A couple of other questions. Dr. Janu, this one's for you. Does TIF fix LPR?
That's a great question. LPR is laryngopharyngeal reflux. Again, these are long words that we don't like saying over and over again, but basically it's a manifestation of the contents affecting more into your mouth and your throat. So LPR symptoms would be like coughing, hoarseness, clearing of the throat in those circumstances. And when we do reflux surgery, we find that about 70% of the time we're doing it primarily for regurgitation, heartburn, chest pain, the kind of the classic, more typical symptoms. But 30% of the time people don't have any erosions, they really don't have any heartburn, and they find that the medicines really don't change much, but they're having these kind of more upper respiratory manifestations, even flare-ups of asthma. Sometimes we've had patients that were actually aspirating where the contents are actually going into their lungs while they sleep. And in those circumstances, it can be very helpful. The tricky part about that is that there's other components that can affect that as well, whether it's sensitivity to the environment, sensitivity to food, or even side effect of medications. And so that's where doing a very appropriate workup to determine how significant the reflux actually is can help guide patients towards a treatment for the LPR. But yes, it can be helpful.
Perfect, thank you. And that she did a lot of tests. So Dr. Janu, do you mind kind of explaining to the viewers what types of tests, diagnostic testing, would someone have to endure, to determine if they're a candidate for the TIF procedure?
Sure. When patients come in, we always kind of talk about this information gathering phase, where what we're trying to do is pinpoint exactly what's going on the insides, so that we could come up with a very definitive diagnosis for what's actually going wrong. Because once you figure out what the problem is, then it's much easier to come up with a solution to fix it. Because there are other things that can cause similar problems, whether it's the esophagus not squeezing as well, or the muscles and the nerves are a little bit discoordinated, or perhaps the stomach isn't emptying as well. Sometimes people can just simply have hypersensitivity or other allergy aspects that contribute to this that cause the exact same symptoms. And so we will typically do an endoscopy where we'll look down inside the stomach with a lighted scope. It's primarily designed to make sure that there's nothing more serious going on as far as like ulcers or infections, cancers, those kind of things. So we'll typically take some measurements, take some biopsies, make sure that there's none of those bad things going on. In many cases, we'll do pH testing at that time, which involves putting a tiny little computer chip clipped to the lining of the esophagus that measures the acid levels, and it can determine how significant it is over a period of time, whether it's 48 or 96 hours. Sometimes we'll do some testing where we'll have people swallow things down that show up on x-rays. I tell people they'll have you come and drink something that might not taste particularly good, but it shows how well things will squeeze down and whether or not it's coming back up. And then sometimes we'll do some additional testing where we'll measure the how well the esophagus is squeezing. I'm not necessarily a farmer, but the esophagus is supposed to squeeze things down, and if it's not squeezing properly, then that can affect some of the patient's symptoms. And what we find is that there's many patients that will have some degree of dysmotility where the esophagus isn't particularly working as well as it once did when, let's say, they were 18 or 21. And in those circumstances, by reconstructing the valve this way, in comparison to traditional fundoplication, which could have a negative impact on some of the side effects when people have that, is that this reconstruction has very little impact or side effect on that. Might not make it perfect, but it certainly doesn't make a negative impact on it. So those patients can certainly benefit from having this reconstruction as well.
Perfect. Let's talk a little bit. We're getting some questions about post-op and what to expect, the day of the procedure and then also after. What are things that patients need to consider after? We talked about the diet a little bit. What's your normal protocol, maybe, Dr. Janu, and then we can ask Ryan, Mike, and Eden about their experience post-op.
So in many ways, working on this area, I try to get people to envision, imagine having your tonsils taken out. There's a lot of swelling that goes into it and whatnot. And for a period of time following the procedure, because there's a narrowing that happens from the swelling, people have to imagine whatever they put in their mouth has to almost go through a funnel or an hourglass to get into their stomach. So I call it a mushy diet for the first few weeks. When I started back in 2010, I started calling it the melt in your mouth diet until somebody asked if that meant taking M&Ms for every meal. So then I kind of changed the name to this mushy diet to get people to just kind of visualize what it would be like to have something that's a little bit softer or a little bit moister that would be able to go down. So it's typically puddings, jello, sherbets, smoothies, cream of something, soups, ice cream. There's different things you kind of mix and match, but as long as it's moist and kind of mushy. And then over time, as the swelling goes down, it becomes less important the what that you're eating and more the how and how much. So people focus on taking tiny little nibbly bites, chewing their food real well, and you end up kind of becoming more of a grazer than a meal eater for a period of time. And then as the swelling goes down, people typically find that they can eat most things that they want. Sometimes bread can be a little bit tricky because it absorbs the saliva and becomes sticky and doesn't go down as well. But for the most part, they can eat what they feel comfortable eating, understanding that they have to kind of follow those caveats of small bites, chewing their food well, eating very little at any given time. So the portion sizes go down a little bit. Most of the time, people end up losing about 10 pounds following the procedure. If you can maintain it if you wanted to by kind of keeping with those portions. We also try to limit people from doing a lot of heavy lifting for about 4 weeks after the procedure to allow the scar tissue to heal. We usually say somewhere 20 pounds or less. You try to do as much walking as possible. Anything that's light aerobic is fine, but you want to avoid the crunches, the Pilates, anything that increases your abdominal pressure.
Yeah, thank you. Ryan, talk to us a little bit about your experience post-op. How was the diet? You survived, obviously. You're 8 years
Sure.
old. And what were the things that you had to that stood out back then when you were kind of recovering from the TIF procedure?
Sure. Yeah, I just ate baby food.
Okay.
I went to the grocery store, stocked up on baby food, and that's what I ate. It was fine. I remember bragging to people that it didn't bother me at all. It was kind of fun.
Oh, that's funny. Okay. And then were there things that you had to, wait to do until you felt like you fully recovered? And at what point did you feel like, okay, I'm not even thinking about the food I'm eating anymore, and I'm just kind of living my life normally? At what point was that for you?
It's hard to say a timeline. I do specifically remember that I was very conservative with reintegrating foods, mainly because I was in a good groove with my little baby food diet. So I didn't feel like a craving or a rush to get back to normal on it. There was some, and I wanted it. I just really wanted it to be successful. So,
Right.
so I want to say like 4 months or something. I was just very conservative with with the diet and exercise and all that kind of stuff. And then I just slowly started bringing that back in there. And I think for the most part, diet, exercise has stuck. I feel, especially right now, I feel really good about where that I'm not contributing in a negative way to any of the success of it. So
yeah. Fantastic. Thank you. Mike, what about for you? You're 6 months out now. What was it like for you? Was there anything that stuck out or at what point did you feel like, okay, I'm feeling back to normal and I can kind of eat whatever I want to eat?
I would say the first week was primarily liquidy type diets, and a blender became my best friend. It seemed like everything that went into my mouth went through a blender first, and I started taking soup, but the soup went through a blender before it went into my mouth too. So mostly it was pretty liquidy, a lot of smoothies, and I was just very concerned that I was going to have a setback if I started eating too much bulky type food too early. I would venture to say, again, 4 to 5 weeks before I started putting things into my mouth that had a little bit more consistency to it. It worked out pretty good for me, and I didn't wreck anything, and that was my goal.
Yeah, you got some pretty good patient compliance, Dr. Janu. Eden, what about for you? What has it been like? 5 weeks out, so you are probably just starting to introduce certain foods, maybe. And don't worry, Dr. Janu won't get mad at you if you tell him you were.
Everybody cheats.
Yeah, so I would say about like the second week, I started having like mashed potatoes with chicken like in it. So it was actually doing pretty good. And then starting like last week, I could actually eat food. So I've been eating like burgers cut up in bread. I've been pretty good with everything. Okay. So I would say I'm doing pretty good. So.
Okay. Fantastic. And as far as being able to do certain things, has that been, physically or, is there anything that you're not able to do kind of right now, or are you starting to like come back to normal, doing things you're normally used to?
Yeah, I would say the main thing is I went back to work 1 week after, and I wouldn't recommend going back 1 week after because it felt like I did 1,000 crunches. So that was the main thing. But I would say like last week I started making my full 8-hour days. So yeah, it's been pretty normal.
Fantastic. Wonderful. We're getting a couple more questions coming in, so just try to get through those. This is actually a really good question. You did answer the first part. What's the typical workup for a patient, Dr. Janu? So you answered that already, but this is interesting. Is there anything a primary care doctor should know or look for in patients that are suffering with GERD?
I think, one of the potential problems with longstanding GERD and reflux is that irritation will cause changes in the esophagus. The stomach is designed to hold the content of your stomach. It's fine, but when things are going the wrong direction, the esophagus doesn't like it. And so some of the more serious manifestations are when people get ulcers, let's say, or the lining of the esophagus starts wearing away. That can lead to bleeding problems. Sometimes there's a reaction where your esophagus doesn't like it so much that it will build up a callus or a thickening to try to prevent things from going the wrong direction. That's when people start noticing food might getting stuck or not going down as well. When people are having a lot of pain with swallowing, that's kind of a sign. And ultimately, the longer that the symptoms go on, you kind of want to at least take a look inside to make sure that there's nothing more serious going on, because esophageal cancer is one of the fastest growing cancers in the United States, and it's starting to manifest itself at a younger younger ages too. And nobody's exactly sure why. Maybe it's diet or lifestyle or any number of other things. But the longer that people are complaining of the symptoms, it's probably worthwhile looking into, especially when people are requiring increasing doses of their medications to try to alleviate or cover up some of the symptoms as well.
Yeah. And so this is an interesting story, right? With Eden, a lot of times it's you see a GERD patient, they've been on PPIs for years, and that's actually a question that's come up is about long-term use of PPIs. But before we go to that, real quick, we talked, you looked at Eden and she just kind of started having symptoms of GERD, and it progressed to a point where it was just, her lifestyle, it's changing, her everyday lifestyle, if you will, and she was ready to do something and make a change. So is that happening more frequently now? Is it because she's younger? Is it just because of, what are your thoughts on that?
I mean, it's a great question. People ask like, why is this happening? And I don't know if there's a great answer for why, because there's so many factors that go into it. The spectrum of age that we've had to operate on ranges from 17 to 87. So whether it's from lifting too many hay bales or jumping jacks or pregnancy or constipation, coughing, time, it can be that you're born with it. There's something about that mechanical valve and its relationship with the muscles of the diaphragm. Because it's a moving part, it can wear down. And some people are more prone to it wearing down than others. And if that valve that's supposed to be this nice little one-way flap valve stretches out or flips backwards, it ends up being kind of like an umbrella in a windstorm where all of a sudden it snaps and it just fails and it no longer is able to provide that barrier function anymore. And that's when people start noticing some of their symptoms.
Right. Right. And then can you talk briefly about, long-term use of PPIs and what the potential side effects could be, or
Yeah, I think in many ways, people believe that when you take the PPIs, whether it's omeprazole or Prilosec or Dexilant or Nexium or Acifex or Protonix or Prevacid, every company that makes a medication wants to be in this market because it's such a big market. And ultimately it ends up treating the symptoms of reflux, but it doesn't actually prevent or stop the reflux from occurring. Well, we do know that long term, the medicines themselves are designed for a 6-week course to treat esophagitis. And after that, there are some reasonably good studies suggesting that it increases your risk of bone fractures over time. It does potentially affect how your kidneys filter because it is filtered by the kidneys. And because acid is a good barrier to bacteria, if there's no acid in your stomach, any bacteria that you eat might be able to get into the intestinal tract and throw off the balance of the normal bacteria that are in there and potentially affect how your body fights off infection. And so there are these kind of long-term side effects, and whether or not it affects dementia or heart disease, those are potential risks as well. Ultimately, what I'll tell patients is that the medicines themselves are good and they're very effective if taken at right, proper doses, and you can take them long term. The problem that I see is that patients are doubling up on those doses or taking several at a time, and they're still having breakthrough symptoms despite those medications. That's when you know that it's gotten bad enough that it's probably worthwhile at least considering doing something to actually fix the problem rather than covering it.
Yeah. Was perfectly said. So, and then a question from John asking, does the TIF fix pH acid levels?
So the pH testing will show that as a combination procedure, fixing the hiatal hernia, if there is a hiatal hernia one there, along with the valve reconstruction with TIF, that the reduction in acid can be up to 92% based on some recent publications that are out of University of California in Irvine. And they followed a large cohort of patients and they combined doing both. The initial studies on TIF were somewhat variable as far as how well it controlled the acid exposure to the esophagus. But those were all patients that only had the TIF done and didn't have the hiatal hernia addressed. And I think that what's happened with time is that we've come to realize how important that hiatus or the muscles of the diaphragm and that component of the barrier actually serves. And so in most cases nowadays, people favor trying to at least fix or address that if that's a functional problem. For patients that truly don't have a hiatal hernia where the valve is just gone flaccid or just not sealing as well, I think this ends up being an excellent way to try to treat that aspect, particularly for patients that are looking for the most minimum that has the least amount of side effects too.
Thank you. And then thank you. And then one last question, and then I want to conclude with everybody. But is it okay to have the TIF redone? So there's a lot of questions here about, can the TIF be redone? How often can it be redone? Does it need to be redone? Does it need to be taken down? It's a ton of questions, but I'll let you kind of just answer them.
It's essentially, it's a very, very rare event that you'd even have to consider trying to take it down. I've only had one patient in my experience, and that was somebody that was referred that had a TIF done somewhere else that wanted to take it down. And usually the biggest thing with this is that it potentially wears down over time. And a lot of times it can come from either the scar tissue didn't heal as well, or hiatal hernia can develop or enlarge. And it's the same issues that go along with traditional fundoplication and its durability and efficacy over time as well. Can the TIF be redone? It certainly can, provided that hiatal hernia hasn't come back, particularly for patients who, let's say, did very, very well initially, and then over several years of time, perhaps the symptoms were trying to come back in some way, shape, or form. So it's really individual. I don't like to go that direction with patients because I'd rather have them have the one and done and have it last for all their life. And provided that they heal well and they do like what they're supposed to do when there's recovery. I mean, Ryan and Mike have done, and even Eden have done fantastic jobs of kind of listening to their body, understanding what they can do and what they can't do, and not necessarily pushing or forcing the issue. And those patients typically are the ones that do the best long term.
Yeah.
And whether it comes back there, you have to kind of identify the factors that led that patient to the symptoms coming back.
Yeah. Very, very good. Yeah, very good. Before we go and conclude this evening, Ryan, I'll let each of you have a chance to answer this question, but if you have a friend or a family member, or someone that's suffering from GERD, what would you recommend to them? Ryan, I'll let you go first.
Like, would I recommend the procedure?
Well, what would you recommend that your friend, or what would you recommend them to do? Go see a doctor? What's the one thing that from your experience and everything that you learned, especially since you're 8 years out having the TIF procedure? I'm not just saying get the TIF procedure, but what are the things that you would recommend that they do if they came to you? Oh, did we lose Ryan?
Think would
Okay.
refer you to one if symptoms were bad enough. So.
Yeah. Fantastic. Okay. Mike, how about you? Any last words of advice for anyone that's suffering?
I would suggest that they try to alter their lifestyle to see if that's going to help out what's taking place in their life. And a lot of times that will help you out significantly. And other than that, I would say explore your options. There are, Dr. Janu mentioned the number of different options there are, and everybody can choose the one that is best suited for their particular condition that they're experiencing.
Yeah, perfect. Thank you. And Eden, how about you? Any last words of advice that you'd leave anyone that might have been or is suffering, especially for you, kind of younger, and experiencing what you've experienced?
Yeah, I'd say definitely explore lab and also see a doctor just so they can tell you more.
Yeah, perfect. Thank you. Thank you. And Dr. Janu, for you, can you just talk a little bit about your practice at Fox Valley Surgical? How could patients or potential people that are watching find you, where you're located, any of that?
My practice has been slowly evolving. We started doing the TIF procedure in 2010. And back then, I really truly didn't have an intention of having this become my primary focus. But over time, with the different options and whatnot, for whatever reason, it seemed to fit me really well. And so we've kind of grown it into this kind of specialty reflux type of practice. And so Fox Valley Surgical Associates in Appleton, Wisconsin here is a group of fellowship trained specialty physicians, and all of us have a specialized niche into what we focus on and what we really like to do. And we try to do it as well as possible. And so people can certainly reach out to the Fox Valley Surgical website. We also put together a website that's refluxwisconsin.com that people can go to that has some of the different treatment options and a little bit of background and information that they can look at. I strongly encourage people to look on the internet and try to research, just like Mike had mentioned. We do patient seminars every so often just to get out in the community so people have an opportunity to ask questions about these kind of things. And I would say that, if you are having some of these issues and it becomes, lifestyle limiting, it's certainly worthwhile to reach out to somebody. For us, I've done about 600 patients with the TIF and about 300 patients with the LINX, and I can't really count how many fundoplications because I've been doing that since about 1994. So I'd strongly recommend going to somebody who kind of focuses that as their niche, because everybody's a little bit different. Everybody might have similar symptoms and similar complaints, but the individual nuances really make it a little bit of a challenge for me, in the sense that what I try to get to patients is the treatment options that's going to be the most effective treatment option with the least amount of risk and side effect for them. And so focusing on that as a practice has been really rewarding from that standpoint. And so between myself and Dr. Michael Black, who's my partner that kind of helps focus in this area too, people can reach out and we'd be happy to talk to them or help them out in whatever way we can.
Fantastic. Thank you, Dr. Janu. And for those of you watching, Dr. Janu's information is located on the top right-hand corner of the screen. So you can, as he had mentioned, visit his website and also contact him via the phone number that's listed up there, and the address is there as well. If you are listening and you're not in that area, we can also go to gerdhelp.com. On there's lots of resources and information about treatment options and obviously the TIF procedure. And there is a physician finder in there as well. So if you're looking for a TIF trained physician in your area, you're welcome to put in your state or your zip code and you'll be able to find a TIF trained physician in your market. All right, well, I can't thank all of you enough for joining us this evening. I know myself here at Endogastric Solutions, we really appreciate your time and your stories and your experience. And then also can't thank you enough for joining us. I know that the patients are the people that are watching appreciate it as well. So thanks again, everybody. And as you know, we're here every Tuesday for TIF Talk Tuesday, so you can catch us next week for our TIF Talk. So thank you again and have a great evening. Good night.
Thank you.